All right, I think we'll go ahead and get started now. Good evening, everybody. My name is Ife Ifediba. I am the co-president of the Student National Medical Association at Washington University in St. Louis School of Medicine. And I'd like to welcome you to the Building Trust in Healthcare panel, part 2. This is part 2 of a 2-part series on mistrust in medicine and what our healthcare system in St. Louis is doing to tackle this. Before we get started, I wanted to mention that this conversation will be recorded and that closed captioning is available for anyone who needs it. Second, before we go any further, we'd like to make a statement to honor the communities that have lived here on this land and from whom we are beneficiaries. In honor of our Native Indigenous American Indians, First Nations people land acknowledgement, we begin by acknowledging that we gather today on the ancestral lands of the Osage, Miami, and Sioux peoples who were removed unjustly, and that we in this community are beneficiaries of that removal. We honor them as we live, work, and study here at Washington University School of Medicine.
Thanks, Ife, for that wonderful introduction. Hello, everyone. My name is Michael. I am the secretary of the SNMA here at WashU. And I just wanted to quickly go over just the background and context for this panel today for people who could not join us for the first panel, and just to give an update as well on some of the themes that we discussed about in that first panel for those that did join us to set context for this one. So without further ado, in the wake of the COVID-19 pandemic, medical mistrust has amplified in the public consciousness, with many communities in St. Louis experiencing a history of generational injustice, implicit bias, racially discordant care, disparities in healthcare access, and inadequate access to health education. We understand that current and future providers must work to promote awareness, transparency, and equitable action for those we care for. This panel is the second in a 2-part series on building trust in healthcare. In the first panel, community leaders Naya Sumter, Atara Estes, and Robin Cole discussed their experiences with the healthcare system as both patients and patient advocates. 2 main themes arose from their insights. The first was a lack of access to quality care. The second theme was a failure of trauma-informed care, which is an approach to providing accessible and appropriate support services sensitive to the traumas that patients have faced. Tonight, we're going to be bringing together regional and institutional leaders that can speak to initiatives planned or currently being implemented to address these themes and related issues in St. Louis. So I want to thank again everybody that has submitted questions for our panelists. And I'm going to hand it off to Ian, who's going to be introducing some of the panelists for today.
All right, thanks, Michael. As he was saying, my name is Ian Marigi. I am one of the co-presidents of SNMA. And next we will just be introducing our panelists as well as our moderator. So I will start with Dr. Fredrick Echols. Dr. Fredrick Echols is the acting director and health commissioner of the City of St. Louis Department of Health, and is the first medical doctor to serve as health director since 2007. Prior to his current role, Dr. Echols served as Director of Communicable Disease, Vector and Veterinary Programs for the St. Louis County Department of Public Health, where he was responsible for overseeing daily operations, strategic planning, fiscal management of a multi-million-dollar budget, and program development and implementation. Prior to starting his position with St. Louis County, Echols served as Chief of Communicable Disease for the Illinois Department of Public Health and as a medical officer in the U.S. Navy, where he managed a staff of medical and ancillary personnel. He is a current member of the National Medical Association, National Association of Health Service Executives, American Public Health Association, Council for Health for State and Territorial Epidemiologists, the American Sexual Health Association, and several other professional organizations and national work groups. I will next be handing it off to Michael, but thank you, Dr. Echols, for joining us tonight.
Thanks, Ian. So I will be introducing Deidre Griffith. So Deidre Griffith serves as the Regional Director of Community Health for SSM Health St. Louis, a nonprofit healthcare system with 8 hospitals in the greater St. Louis area. In this role, she provides leadership on a wide range of evidence-based initiatives focused on addressing social determinants of health, advancing health equity, and strengthening community partnerships. Deidre Griffith serves on multiple community coalitions, including the Regional Health Commission, where she is a member of the Provider Services Advisory Board. Prior to joining SSM, she served as a program director at the Missouri Foundation for Health, where she provided strategic leadership on multiple health initiatives, including childhood obesity prevention, public health infrastructure, the Opportunity Fund, and healthcare workforce development. Thank you so much, Deidre, for joining us today. And I'm going to hand it off to Iffy, who's going to introduce Ms. Jacqueline Randolph.
That's right. As a recipient of the 2021 Champions for Diversity and Inclusion Awards, Ms. Jacqueline Randolph is a leader invested in health equity and access for all community members in St. Louis. Jacqueline Randolph serves as the Executive Director of Ambulatory Services at Barnes-Jewish Hospital, serving 15 hospitals in the greater St. Louis area. Among the many initiatives she leads is BJC Healthcare's public COVID-19 vaccination campaign, where she guides work on addressing 2 causes of lagging vaccine rates in Black communities: lack of access and mistrust of the medical establishment based on historic abuses. Excuse me. Additionally, she also manages the Community Health Workers Program at Barnes-Jewish Hospital, which works to meet and overcome disparities in healthcare, as well as contribute to the development of a food insecurity screening program, which identifies patients living without reliable access to affordable, nutritious food. Thank you, Jacqueline, for joining us.
All right, next, thank you all of our panelists for joining us tonight. I will next be introducing our moderator, Dr. Will Ross. Dr. Will Ross serves as the Associate Dean for Diversity, Principal Officer for Community Partnerships, and Alumni Endowed Professor of Medicine in the Nephrology Division at Washington University School of Medicine. For over 2 decades, he has recruited and developed a diverse workforce of medical students, residents, and faculty while promoting health equity regionally, nationally, and globally. He has been instrumental in redesigning local access to healthcare for the underserved as the founder of the Saturday Free Health Clinic, co-founder of Casa de Salud Health Center, and founding member of the St. Louis Regional Health Commission. He has served leadership roles in numerous regional and institutional health organizations, including the St. Louis City Department of Health as Board of Health Chairperson, the Mid-America Transplant Service Division, and the Center for Disease Control as a member of their Health Disparities Subcommittee. Thank you, Dr. Ross, for joining us tonight. And with everyone introduced, I will be handing it off to you for the panel.
Well, thank you, and good evening to everyone. I really appreciate SNMA, Ian, Michael, Iffy, and all the SNMA members for putting this panel together. Fantastic group of leaders, pioneers in the field, making things better for all St. Louisans here. Jackie Randolph, Deidre Griffith, and Dr. Fred Echols. I know them well, and I have tremendous respect. Before I move on, I want to just pay honor to the panelists from the last session. They were powerful, and I hope that they know that the impact they had. Naya Sumter, Atara Estes, and Robin Cole gave very gripping personal stories, really speaking truth to power in their focus on addressing racial equity in medicine. And so we're going to hear more from those providers, key administrators about how to affect serious and longitudinal change, long-standing change in this healthcare system. And so we're going to start out by having each of the panelists speak a little bit more about their work, and I'm going to have them to honor the time constraints. We want them to spend no more than 3 minutes a person doing this. Well, actually, I'm sorry, we won't go that route. What I'll do is actually just going to go over the agenda. We'll share their, have the panelists share their work, and I'm going to talk about that a little bit more. Then we'll have them transition to the prepared questions, and then we'll have the audience question and answer. And so the initiatives that I want the panelists to speak on, and prior to speaking on this initiative, then they can comment on an issue that really has connected them to this whole focus on health equity. So here's the initiative. Failure to provide trauma-informed care, implicit bias, and healthcare access were all highlighted as causes of breakdown in trust during our discussion with patients and patient advocates. So could you please briefly describe one or two of these initiatives you're working on that addresses these issues? And so we'll start, we'll go alphabetically with Fred Echols, then Deidre Griffith, and Jacqueline Randolph. And so again, just time period, I want to make sure we adhere to that 3 to 4 minute time allotted.
All right, thank you, Dr. Ross, and the Washington University SNMA chapter for the work that you all are doing. In the city of St. Louis, one of our responsibilities, or one of my responsibilities, is overseeing all public health initiatives. And we know that racism is a public health issue. It's been declared a public health issue by many national organizations, and our Board of Health and Hospitals has also done that locally. When we look at what has transpired over the pandemic, the things that have been highlighted are not new. And so one of the things that we have to do is look at how we're addressing those issues, particularly how we're addressing the root causes of these issues that continue to be highlighted as we navigate through the COVID-19 pandemic. One of the issues that has come up repeatedly is the lack of health advocacy or lack of knowledge about health advocacy within our community, particularly communities of color who has been disproportionately impacted not only by COVID-19, but by other longstanding chronic conditions such as hypertension, diabetes, chronic lung disease, which all, again, increase individuals' risk for severe complications to COVID and other communicable diseases. And so making sure that the community is aware of how to properly advocate for themselves is really important. So one of the initiatives that the City of St. Louis Department of Health is spearheading is one focusing on the CLASS standards, and CLASS stands for culturally and linguistically appropriate services. So the federal government has established a blueprint for all organizations that receive federal funding to ensure that individuals who receive quality care, but it's also, we want to make sure that the quality care is provided equitably so that the quality of the service isn't dependent on an individual's race, ethnicity, socioeconomic attainment, or education attainment. And so this is one thing that the health department is spearheading. So there's a communication campaign that's being launched to really empower communities about the CLASS standards and what this actually means for them. And it helps give them a voice so that when they receive care at a particular entity, they'll know what's acceptable and what's not. And if they're the recipient of unacceptable care, there's a means by which they can report that to the federal government and to the local institution. And the other thing is we're also looking at, we collect a lot of data within the health department. And so implementing data-driven approaches to all of our programs also helps ensure that the initiatives that we implement focus on the needs of those who really need the services. And so that's something that we've done over the course of the pandemic. And one prime example of that is where we placed the monoclonal antibody infusion treatment center in the city of St. Louis. We know that the northern part of the city has the highest burden of COVID-19. And so it's really important for us to make sure that those services were made available to that population. And unfortunately, when you implement racial justice approaches, it's not always received well by communities who are used to receiving those services. And so we're battling with that right now, but that hasn't steered us away from meeting the true needs of the community by implementing approach that's focused on racial justice.
Deidre?
Good evening, everyone. I'm really pleased to be here. Thank you for this opportunity to share. So at SSM, we are, of course, experts in healthcare. However, one of the things that I've been working pretty diligently on since I arrived at SSM a little over 2 years ago is improving our community connections and our community partnerships. We're very clear that our communities most in need and most marginalized have the most inequities when it comes to healthcare. So one of our approaches has been to, again, play that role, be the experts in healthcare, but reach out to community partners, have meaningful relationships with our community partners so that we can address more of the social needs and social determinants of health that we know our patients are arriving with. When they come to our services, they may come, they're coming as individuals in need, individuals unhealthy, but we also know they're bringing with them the needs of their communities. So as part of our efforts to address some of these issues, we have partnered with organizations such as St. Patrick's Center and the Salvation Army on a very high touch strategic initiative to address the needs of our homeless population. We have formal agreements in place with those organizations so that, again, it's not just a referral that we don't know what has happened to that patient, and that has been an issue for our health system. I don't think we're alone in that, where when we're referring patients to community partners, it's hard to know where they end up. So in high touch relationships like these that we now have in place, we're really able to keep our finger on the pulse of how our patients are progressing through their health needs, as well as through managing their housing needs. We also are very focused on access to care in our last community health needs assessment that came out loud and clear. So such as in our South County area and our Fenton St. Clair, we've partnered with an organization called ComTree. You may know of them. Wonderful community organization that serves the needs of uninsured or underinsured patients, but really focused on a community care coordination and coordination of social needs. In our North County DePaul area, we're really focused on food access and food insecurity, working very closely with community partners out there, such as Operation Food Search and IFM Community Medicine, St. Area Food Bank. So we're really working very hard, again, to be present, meet the community where they are, understand that we have to do much more if we're going to be able to address whole person health and not just the physical health needs. One of the things I am excited about that we're partnering on with United Way and many of our other health systems who are represented here tonight is the Central Information Exchange, where we're hoping to be part of a regional approach to a more systematic referral system, meaning that, again, we have to get out of this cycle of just assuming, someone in need who has a social need is getting the needs met, and we just kind of have a cold approach and a phone call that we don't know where it landed. This would be an opportunity to have a much more robust process, again, partnering with many community partners as well as our other local health systems to have a more engaging referral process for meeting social needs. So those are just some high level approaches that we're taking to address some of the issues that we're talking about this evening.
Thank you. Now, Jacqueline.
Yes, good evening, everyone, and thank you for the honor to be here tonight. And I really want to share a few models and approaches to addressing some of the social determinants of health. But I think one of the main foundations of this work is communication. making sure that we clearly communicate with our communities and ensure that we're not making assumptions for what their needs are. So we have established a community health worker program within our primary care medicine clinic. And the community health worker's role is really to be that navigator through the healthcare system and to address the noise around a lot of things that's happening to our patient populations. It's not always the medical or chronic condition that causes patients to be readmitted to the hospital or to be utilizers of our emergency department. So we want to make sure that we are addressing, as Deidre said, kind of the holistic approach to our patient populations. We're also looking to transportation needs. And our biggest communication piece around that is not per se waiting for a patient not to show up, but getting in front of that and reaching out to our patients to say, hey, you have an appointment. Do you have transportation? What are those things that we can help you with to ensure that we can care for our patients in a way that is not a burden for them? The trauma-informed care model is not new to anyone on this panel or probably anyone that's listening, but the important piece for us and everyone else on this panel, I'm sure, is making sure that it's a two-way street, that our staff knows what trauma-informed care is and helping the patient understand what that trauma-informed care is about for them. Connecting with our patients in a way monthly. We have a newsletter that goes out to the team to teach them about a different culture. So if you have a patient that comes in that maybe just want to take their shoes off because that's a part of their culture, we need our staff to understand that, and we need to be able to respect the different cultures that are in our community that we need to care for. So we continue to have open dialogue with our community partners, with our patients, with our staff, and the continuous learning. Health literacy is both for the patient and for our staff to ensure that they understand and the patient understand with the teach back model and several different strategies that we use to make the patient feel welcome and be seen. We want them to be seen and heard and understood and walk away from their interactions with our team with the feeling of someone cares. And it's not just about the hypertension or the diabetes that I came in here for today. They care about me as a person. They care about the place I live and work and go to church and all of those important things. So we really have a foundation of communication with our patients and making them feel like there are healthcare providers who care about all of the things around you and all the things that are happening to you, and not just making assumptions of these are the things that you need.
Thank you. So you can clearly see these are just phenomenal thought leaders and who have a remarkable grasp on these really issues, deep-seated issues of trust, understanding of social determinants of health, engaging the public. And really, they all spoke on really providing culturally sensitive care, care that really is trauma informed. And so, what we want to do is offer a number of questions to our panelists. They're going to speak on these over the next 30, 40 minutes, and then we'll open the whole forum for input from you as guests. And I already have started providing your questions. So I'm going to pose these questions to one particular panelist who will respond initially, and then after their response, the other panelists can provide their perspective. I'm going to start off with you, Jacqueline Randolph, since you really spoke about this issue of trauma and trauma-informed care. And we know that a lot of this discourse, the national media discourse around medical mistrust is centered around historical traumas. But insights from our previous panel suggested that patients' everyday experiences of bias and insensitivity from health providers contributed significantly to breakdowns in trust. Can you speak to the initiatives that you've been engaged in that improve interactions between patients or providers? For example, programs that implement bias or cultural competence training. Either you've been involved or you are aware of these, and kind of provide to our audience what incentives exist to reward providers who demonstrate these practices of doing trauma-informed care, and how can we hold institutions accountable for providing care and addressing issues of insensitive care? So that's for you.
Thank you for that question. To break that down a little bit, I'd like to first say that when we onboard our staff, and I keep going back to the staff because these are the folks that are boots on the ground, that's touching the patient and at the bedside. And so we at BJC, or Orange Ridge Hospital, we have an onboarding process where we talk about St. Louis. We talk about the Ferguson issue. We talk about why there's mistrust in our community. And so that takes us back to my first response around communication and building relationships. So we roll that out in a way that even to be a part of our organization and to come on board, we want you to understand what you're walking into. And then we roll that out to our patients. So we have several programs, and I'm going to speak specifically to our women and infants, because that is a space where we all know in the St. Louis area that there are trust issues, moms having babies, and they think back to the time where Black women were not given the same opportunity as other races when delivering babies, and the mistrust there. So we provide training and education in our OBGYN clinic to moms and babies, involving the father, and doing incentives programs to ensure that in our teen pregnancy clinic that these patients want to come back. We do incentive programs called Baby Bucks, where if you keep your appointment or you get good grades in school or do any of those things, if you bring a father, the child's father, to clinic with you, we give you an incentive to come back, and then you can use these Baby Bucks to shop in. We call it a store, but it's actually just a room in one of our clinics where we allow them to go in and purchase extra diapers or car seats or things for their children right there in clinic. We want to make the patient feel like this is a place where you can trust us. We have a very collaborative relationship with our social workers, our case managers. There are representatives in our clinics that can sign you up for Medicaid. So we want everything that you need to be right there in our space, and not just hand you a piece of paper and say, hey, go do this, or give you some instructions that you're not going to, discharge instructions that you're not going to understand or not follow when you get home. The other thing is really following up with that patient once they leave for that visit, connecting with them in a way and building relationships, making sure that the people caring for you look like you. So we have a very diverse staff. And so it's easier to build a relationship with someone and trust them if they know your story or they understand your experience and you're comfortable talking to them about what happened to you instead of what's wrong with you, taking that approach. So lots of programs and incentives for them to come back and develop a relationship. We really try to have our nursing teams, if they feel comfortable, our nurse practitioners, our mid-level providers, if they feel comfortable with the patient, we want them to establish that relationship early and be able to pick up the phone and call them. And our community health workers also help with that, because they will go and see patients while they're in the hospital and establish that relationship with them, build that trust and say, we care about you. Here's my phone number. You call me if you have a problem and you don't feel comfortable talking to a healthcare provider.
Yeah, powerful statements about truly institutionalizing anti-racist policies and practices. Thank you. Our other panelists want to comment on that question?
Sure, I'll give a couple moments to talk about this. So in the city of St. Louis, one of the things that we prioritize is making sure that all of our staff truly understand the history of health care delivery for indigent populations in the city of St. Louis. We know that history is not one that we're exactly proud of, but is one that we have to acknowledge if we're really serious about establishing a good relationship or a new foundation with the community and creating a good path forward so that we can start to rebuild the trust that has been lost over the past few decades. And so one of the things that we did was we made sure that all the City of St. Louis Department of Health staff had access to the information that has been documented over the past years, so they understood not only what was happening in the city of St. Louis, but we also wanted to take it a step further and also make sure that the staff understands how system work, because there's an issue of intersectionality that really helps to further widen the gap as it relates to disparities and health outcomes in the city of St. Louis and across the nation. So understanding the role of intersectionality and how the systems really play a role in perpetuating racism is really important. And so we've integrated racial and health justice in all of our programs that are being implemented in the City of St. Louis Department of Health, as well as making sure that we acknowledge the harm that the City of St. Louis Department of Health and other government agencies may have caused to these communities that are disproportionately impacted by all chronic health illnesses, as well as COVID-19. And by doing that, we really set we set the tone for engaging them in a way that's really fruitful, in a way that can really create a new path forward. And I think unless we acknowledge the work that the harm that we've done, even though we may not have been in our current positions when the harm was being done, we have to acknowledge that the damage that has been caused is a part of our agency's brand. And so that's really a critical step for us, not only, again, building trust within the community, but also making sure that we are able to empower community in a way that helps them to achieve optimal health.
Thanks. So yeah, dismantling systems of oppression and racism takes time. There's no excuse for moving. We need to move aggressively to create anti-racist systems, but it does take time. And I appreciate that perspective on how to do this and how to really empower your staff, the health department, to truly accept this as a moral responsibility. Deidre, any response? Or?
Yeah, sure. So at SSM, we're working very hard, very proactively to address, again, generations of inequities. Our diversity and inclusion department has been very, very active in providing education on inequities, on implicit biases for all of our leadership across all departments. But of course, we especially want to engage our providers. I myself, over the last couple of years, have led several sessions across all of our St. Louis ministries, hospital ministries, on social determinants of health and health equity. As I mentioned earlier, we're really just trying to empower all of our staff, our leaders, our physicians, our nurses, all of our providers to understand, again, what health inequities are, what they look like when our patients show up with them, and what resources are out there to help them address those and help our patients. I've met a lot of physicians and nurses since I've been at SSM, not all of them, of course, But I found that they're all mostly incentivized by healthy outcomes for their patients. It's just that they're all at a different place when it comes to understanding, again, these inequities and situations that many of our most marginalized communities show up with. Some of them fully get it and fully understand. And so you don't need to put as much resources and information right in front of them. Some of them know, but you just need to really make it easier for them to understand, again, what the best approaches are, what the resources are out there to make it easier for them to help patients in need. And one of the things, the last thing I want to recognize is just that, just like it's, we always say it's easier for, to fix or help our kids grow up healthy than it is to, get a adult to change behavior. It's probably a lot like that when it comes to physicians. If we can, as we're educating them, as many of the programs you lead, Dr. Ross, while they're in medical school, so that they are very aware of this before they are practicing for many years and, taking up some bad behaviors, perhaps. It's really great if we can do it on the front end. And I really want to acknowledge a couple of WashU students who have been helping with our community health needs assessment focus groups, because we really weren't sure we were going to pull off the focus groups this year for our community health needs assessment. A couple of WashU students stepped up to the plate. My assumption is that they're really learning a lot about what our most marginalized communities are dealing with and what they want healthcare to do to help address their needs. Having those kinds of firsthand experience for our med students, I think, can be very powerful and impactful as they begin practicing in the long term.
So a follow-up to that, Deidre, I really agree. Those are powerful experiences. Both you, Fred, and Jackie just spoke to what you're doing to institutionalize these practices. When individuals have been socialized to believe and act a certain way, it takes some time to really deconstruct that belief. And so what can we be doing? I mean, you mentioned getting individuals out into the community, getting them to encounter different perspectives, different belief systems. What can you do? What do you envision should be done? Things that we've tried to do before with students and trainees. What can be done at the healthcare system level, at the public health level? And anyone can respond to that question.
I think I'll start. So giving them exposure is really key, right? So making sure they're exposed to cultural sensitivity and what that means and how that actually impacts health outcomes for their patients is really important for them to understand that as they go through medical school. So when they are providing, as Deidre Griffith mentioned, so when they graduate and they're starting to provide healthcare services, that they don't have to relearn that. They don't have to learn that on the fly as they're out and we're really trying to fit into the business of medicine, right? Because oftentimes the business aspect of medicine doesn't necessarily support trauma-informed practices, right? Because it means you have to spend more time with patients to really learn what their plight is. And so with them competing with the business model can really create a lot of tension. Just because there's oftentimes nowadays physicians, particularly in private practice, can struggle to stay afloat because of the business requirements. And so if they're able to incorporate cultural sensitivity training while they're in medical school, as well as create opportunities for them to go out and shadow physicians that really work with marginalized populations so they can have that exposure that can really help them and make them a better or more well-rounded medical providers.
Thank you, Fred. I really appreciate that. There are so many avenues to go with that question. I wanted to keep on going, but I'm trying to rein myself in. These are great responses. Let me go to the second question. I'm going to pose the second question to you, Deidre Griffith, and then the other panelists can weigh in. A second concern raised in the first panel was inadequate care, including unkempt or uninviting facilities and long wait times. What programs exist to monitor and evaluate the performance of the clinics and patient services at the regional or institutional level?
Well, I am primarily community facing. However, at SSM, I do know that we have several structures in place to address any of such issues. We have a grievance process that a patient can go through. It's a formal process. They are able to submit through an online I think they can actually call as well, but a couple of routes through which they can express any issues they may have experienced. We actually just recently hired a system director for patient experience. I'm really excited about that. I'm looking forward to meeting her. And it's my understanding that, you know, it will be under her purview to make sure that our patients are getting the best experience possible. So we do have supports in place. I don't know the ins and outs of all of them, but I know that SSM takes patient experience very seriously. And in fact, I do know that many of our key performance indicators, KPIs, as we call them, are very much centered on patient experience and patient outcomes. So there are many, again, supports in place and structures in place to make sure that we're not ignoring them when things are not on track. They're in front of folks through a KPI board or whatever the mechanism is, and that they are addressed to the best of our abilities.
Other panelists want to weigh in on that question?
Sure. So one of the other things is, again, we have a PFAC, a Patient Family Advocacy Committee, and the purpose of that committee is to inform us from the lens of the patient and their families. So as we all know, as healthcare providers, it's not really just about treating the patient, but their family is a part of that care. So listening to our patient advocacy committee and sharing experiences to know that I don't think any healthcare worker shows up with the intent to not do well. And the one thing I will say with COVID, it taught us a lot, right? How to work different, how to be different, how to care different. And one of the ways that we're working to reduce the extended wait times or the time it takes to get an appointment is offering virtual care. And I'm sure, Deidre and her team's doing that as well at SSM, but that is another option that we're offering our patients. If we can't get you toes in the door, we certainly want to lay eyes on you virtually to reduce that wait time and to guide you on, yes, you do need to go to the emergency room or you need to come in to see us, or this is a routine visit, which will open access for other appointments if we can care for some patients, virtually. The other thing too is creating different mid-level care nurse practitioners or nurse visits to reduce the burden on the physician who can only see so many patients within a shift or a day. So just using different strategies on how we can be available for our patients and to ensure through our patient satisfaction scores, our verbatim comments, and other resources, just listen to what they see and understand it from their lens. Because what we may see as clean, another patient may not. So really just relying on the feedback that we're getting from our patients and our families and creating new strategies in order to create a visit type so that patients don't have to wait as long. And that is a reason why they feel like you don't care. You don't care because I can't get an appointment for 3 weeks, right? And I don't think that is just true in our marginalized or under-resourced communities. It's true across the board, just from the backlog that we've had, with COVID over the last year. But even prior to that, long waits are not acceptable, and we need to find ways to reduce that time for patients to be seen.
Yeah, thank you. We need to recognize and respect the patient's realities, rather. Great. Any other comments? Let's move to the third question. I'm going to pose it to you, Fred. And it's one that you and I have talked about a lot. The COVID-19 pandemic has shown us that safeguarding individual and public health depends on the effective exchange of information between health providers and the public. How should we approach bridging the gaps in the public's knowledge regarding science, evaluation of science, and interpreting data in the context of clinical practice? And boy, I know you can really roll with that one.
I think the start is really valuing the lives of the population that you're responsible for caring for. So how we communicate with individuals is evidence of how we care for them. And so from the beginning of the COVID-19 pandemic, we prioritized making sure that we were able to bring the community along this journey we call the COVID-19 pandemic with us. And by doing that, we were focused on making sure that the information that we issued to the public was consistent with evidence-informed practice, so making sure it was clear. I believe Jacqueline Randolph mentioned that before, making sure it's clear and making sure we aren't using a lot of technical jargon that really that may not be understood by the general population, but also making sure that they understood the why behind decisions that needed to be made. So over the course of the pandemic, we've had to issue different health orders that have placed restrictions on individuals, as well as created some unintended consequences, but were necessary to mitigate the spread of SARS-CoV-2. But we were able to have it be as successful as we've been because we explained the why behind the decisions that needed to be made. And that's something that is also really important in the clinical setting. You know, my family is impacted by diabetes, hypertension, chronic lung disease. And so by working with providers that are able to clearly explain why certain decisions, why certain actions need to be made outside of the clinic. So when they leave the doctor's office, they need to be empowered to say, okay, I need to do X, Y, and Z, whether that's implementing modifying their diet, increasing exercise, or implementing these other strategies to move them closer to achieving optimal health. They really need to understand that. And so we need to meet them where they are. And oftentimes that's more difficult because we have to process our own bias when we engage individuals in the community, especially those who may not look like us and those who may not communicate the way we communicate. And so by taking a step back and really trying to figure out the plight that this individual that's in front of us is experiencing is really important. That way we can make a decision based on that individual's holistic needs and not just based on a disease process. Because oftentimes, as when you go through medical school, you're trained to treat the disease process, but you don't necessarily trained on how to treat the individual. And so that's something that's really important as we move forward in the city of St. Louis and the St. Louis region. It's going to be really important for us to really increase our value for the population that we're charged to serve, especially those who we consider the most vulnerable. Because not often do they often get the short end of the stick, but oftentimes you cut the stick off and then you throw the stick away. And then they're left to fend for themselves. And so we wonder why the community feels hopeless. We wonder why they don't engage us the way we think they need to engage us, but it's because of the actions that we've taken over the past. And so we need to really reflect on our own actions, address our own biases internally, whether it's the part of the organization or each individual provider. We need to make sure that we are aware of our actions and how that can impact the health outcomes of others.
Yeah, powerful statements. Deidre, Jackie, any comments?
No, I think Dr. Echols summed it up pretty well. I think Dr. Echols summed it up pretty well for us.
Okay, well, this segues really well into the next question, because there's just rampant misinformation out there, not just about COVID, but about healthcare in general. We all encounter this on a daily basis. So what do we do to mitigate that information? It really requires really effective communication strategies, time-tested strategies. So 6 questions really regarding communication. An important part of building trusting relationships is the establishment of effective bi-directional channels of communication. Many of our panelists reflected on specific concerns they've had with the care and efficiency of facilities they receive treatment in, and it is unclear how well such concerns were communicated to administrative leaders. At the institutional regional level, how is direct patient and community member feedback collected and incorporated in the design of new initiatives and the prioritization of financial resources? So essentially I'm asking, how do we create effective channels of communication? How do we reinforce those? How do we provide feedback so that the patient or the person in the community really feels that they have been heard and respected? What are some of the mechanisms, approaches that you've all used to really facilitate bi-directional communication? Let's start with you, Jackie.
Sure. So I may have mentioned earlier, Dr. Ross, that one of the best tools that we have is our patient satisfaction scores. So patients are randomly selected. So the provider does not know which patients will be contacted by an outside company. And there's a series of questions about overall quality of care, safety, teamwork, and all of those key drivers that we definitely want to meet for our patients. So they are randomly selected. They're contacted within a time frame of their visit and asked a series of questions. They don't have to give providers' names, just basically the location where they were treated, and are able to give a score along with verbatim comments. That comes back to the department monthly, and then we get a quarterly score. The reason we get them back monthly, because we don't want to wait till the end of the quarter to address somebody that may have had a concern, right? Because that would be perceived as, well, you don't care. You asked me, but you're not going to do anything about it, right? So the manager is responsible for reviewing the verbatim comments and the scores with the entire healthcare team, address it, and figure out how we can make that better, because it may be a perception, but perception's reality. And then they reach out to that patient to really kind of understand why they walked away with the perception that they did, and how and what can we do to reduce that.
Jackie, you dropped off briefly for about 2 sentences. Can you go back and repeat that?
Oh, I'm sorry. So I was explaining the process for our patient satisfaction scores. They are reviewed by the leadership team of the area with the entire healthcare team. So we want to know from the patient, why did you leave with the perception or the reality that you did, and what can we do differently next time so this doesn't happen? An apology is only worth the words that you use to apologize. Patients want actions. And so we try to make sure that what we may perceive as a solution is what the patient is satisfied with, to say, we're sorry you left with that perception. How can we do that differently this time and next time?
Great. Really powerful, being recognizing our vulnerabilities and saying that, yes, we may have issues here. What can we do systematically to resolve those? Appreciate that. The other panelists want to respond.
I think SSM's process on patient experience is much the same as BJC, so I won't focus on that, but I will say a little bit about our community input, because we are just wrapping up our community health needs assessment, which occurs every 3 years. And thank you to all our hospital partners here who did along with us, because theirs aren't due until next year. However, one of the things that I think we can do differently and better going forward is not waiting 3 years for community input. So this year, I'm very grateful to say that not only did we get stakeholder input, we got community input online, and of course, thanks to the WashU students, we got some input from individuals through through focus group. Of course, we're looking at secondary data as well. When that assessment is complete, working on that now, it really should reflect what the community said. If it doesn't, then we are going to have a problem. So when we finalize those assessments and build the associated community health improvement plan for our hospital system, the plans need to reflect the identified community health needs, the health needs that were identified by our community. And so one of the changes we can do in the interim is just going back, not just putting the plan up on our website, but going back to all the community partners who helped us, saying, you know, here is our assessment, here's the plan. We want to proactively share it. And I would really like to do interim meetings, interim focus groups to the extent possible to make sure, again, we keep our finger on the pulse of what the community needs and how they feel about how we are carrying out our community health improvement strategies. So just not being silent for 3 years until the next one too, but continue to stay present. Yeah.
Appreciate that. Fred?
The health department was part of, similar to SSM. So we have our community health assessment, as well as our strategic planning process, where we look to engage community members to participate and have an active voice through that process to ensure that the priorities that are established truly reflect the needs of the community. That's something that's ongoing. And so our strategic plan is a living document that we revisit regularly, and we update as needed to reflect, again, any changes in the community, as well as reflecting the changes in data that we're seeing in the city of St. Louis. We also are working to engage community on a more regular basis. So for example, we're now issuing, we just issued a campaign which started yesterday, as a matter of fact, where we're seeking community input for health and public health and educational materials that need to be prioritized for the upcoming year. So this is something that really gives community a voice, and our way of providing feedback to them will be the products that are developed after we receive their inputs regarding the health and wellness priorities that are impacting them and what they've deemed to be the true priorities for not only their neighborhood, but for the city of St. Louis. And so we look to create additional opportunities for the community to provide, not only provide feedback or input to some of our initiatives, but also want to engage them ongoing, because we know that the more we engage them, the more trust they'll have over time. But it also gives them a sense of belonging, like they have something to belong. Hey, I contributed to this initiative. I contributed to the improvement of X, Y, and Z in the city of St. Louis. And so we really want them to be involved and engaged and involved in public health. Because as we've seen over the COVID-19 pandemic, public health, it touches everyone and everything. And so we really need the community to be at the forefront of all of our decision-making. And that in our mission, part of our mission at least, is to make sure that they are front and center with all of the decisions that are being made.
Thanks. So all three panelists have really effectively addressed issues of curbing misinformation through concrete strategies and approaches. And I hope our audience really really grasp what they were speaking on. This is more than just abstract, that they really are preaching this. And so let's delve a little bit more into this issue of really concrete practices. And if, we're going to be opening this up to those questions from the audience. But there's one particular question in the chat right now, and it's directed initially to you, Deidre Griffith, and then we're going to have the others respond. And it's around the grievance reporting system that you mentioned in your facilities. Is it a regular practice to inform patients about its existence at every visit? They were just wondering if something's always brought to their attention versus something they may not know about without prompting.
I'm not sure what the promotion or communication strategy is behind ensuring that patients know about it, but I do know that any well-trained and well-intentioned provider who's aware of a patient who needs to express anything would share that information proactively with the patient. It probably is on the website. Again, may not be the easiest to find. So again, I'm not sure about what the promotional strategy is behind that process, if there is one. But I do know that our providers should be well informed and trained to share that and many other opportunities for input with our patients.
Jackie and Fred, similarly, in terms of capturing information about grievances, getting those aired in a transparent way and acting upon those, what processes do you have to make that happen?
Yeah, so transparency is the key, right? So we have signage in the patient exam rooms and throughout the clinics to say you may receive a call about your experience today. All of our pictures from the executive director, the manager, assistant nurse manager are posted when you walk in the area to say, if you have an issue, you can contact this person today, right now, to talk through whatever that issue may be. And then, of course, there's a solid process to go through our patient experience team that's on staff there at the hospital, where you can contact them. And then we try to do rounding, and patient rounding consists of the manager connecting with patients either in the waiting room or when they're checking out to say, how was your visit today? Here's my card. If you have any problems, because the patient may not want to speak to it at that moment, feel free to call me. So we try to be as transparent as possible that you have a right as a patient to be seen and to express any concerns that you have during your visit.
Great. I love that transparency. The patients feel heard. I appreciate that. The other panelists want to respond or offer any really practical and concrete ways of addressing grievances?
In the health department, so we receive a variety of different types of complaints. So a lot of those complaints go through our Citizen Service Bureau, and so they're routed to the appropriate department. And then once we receive the complaint, we'll investigate the issue, whether it's through our Environmental Health Services Division or through our Communicable Disease Division, and then implement the appropriate measures that are needed to address the issue. Then oftentimes we'll actually reach back out to the complainant to make sure that they know what actions have been taken by the City of St. Louis Department of Health. In addition to that, we do have some medical services that are contracted out through Affinity Healthcare and Washington University. And so part of the federal standard or federal requirement is for there to be signage about the grievance process. So people will know what number to call, who to reach out to in the event that they receive what they consider to be unsatisfactory care. And then those individuals, as similar to the process that Jacqueline and mentioned, they'll be contacted by a representative from the organization to hear what the concern is, and then also let them know what steps will be taken by the organization to address the issue.
Any responses? Oh no, Deidre, did you hear me? Any responses? I don't know if I broke off there. Okay.
Oh, sorry about that. Yeah, so again, I think we're gonna, well, maybe not mirror the health department with the Citizen Service Bureau structure, but with BJC and what Jacqueline noted, again, we are looking at that patient experience data on a regular basis. It is front and center, again, on our KPIs that I referenced earlier. It's not something that it's looked at the end of the year. It's something that is looked at monthly, and when adjustments need to be made, I know our leadership makes every attempt to make those adjustments. It just depends on the department from which it came.
I appreciate those responses. Again, very candid discussions. Now, as we pivot to other questions that may come up, I think there is one really key question to discuss among the three of you. And that is, in the prior panel, all panelists actually provided recollections of experiences, negative experiences that they've had in our hospitals, even some of the community settings, where there were obviously major issues of distrust, leading the panelists to feel that they were dismissed, they were ignored, or that they felt unseen. And so, it was painful to hear that, and I know that goes on and still on a regular basis here in our hospitals in 2021. So let's talk about really how do we address this mistrust, in a systematic way. You've been talking about processes, all three of you, for really doing this and addressing this. So I want to take this up to the next level about strategies, really good long-term strategies and building trust. One strategy, of course, is to validate the person's community experience, to validate their lived experience. And we don't always do a good job of doing that. We interrupt our patients too frequently. Within seconds of them presenting, we always interrupt them. So how do we actually validate our patients' mistrust as a part of implementing a good preventative measure? What's the best mechanism that you can think of? And anyone can take that question.
So I would say first, acknowledging what the patient is saying, feeling, and seeing. We value respect. I think everybody on this panel could agree that respect is our number one value of communicating and connecting with our patients. You can get the best care, but if you don't feel respected as a patient, then all of the great work that you're doing and all of the great outcomes that you're getting really doesn't matter to that patient. They have to feel respected. And so in order to do that, acknowledging what the patient is saying to you and what they are feeling, and then ongoing sensitivity training. Again, I don't think that the intent is to disrespect or make a patient feel unseen. Sometimes it may just be as simple as it's a busy day and you're going on your way and you're just trying to get your patient taken care of. But you have to pause and be sensitive to, what does that look like for the patient? What does that feel like for the patient? And what do they see? And what do you see as a healthcare provider when you are looking into that patient's eyes? Being authentic is the key to patients feeling valued. Not speaking above them, speaking to them, understanding their story, listening, all of those things that really is going to matter to the patient, I think is the very first step in addressing what patients are feeling and building that trust and helping not just the patient, but the providers understand this is what matters. It's not just about the prescription that you're going to give them or the discharge instruction. What matters, not so much of what you said, but how you made them feel. And we have to embed that into our culture of healthcare, that we have to make people feel like they are accepted, that they are wanted. We want you to be here. We want to care for you, and do ongoing sensitivity training so that everybody involved understands that this is where we start. I think Dr. Echols said earlier, meeting people where they are, understanding and accepting and acknowledging what our patients are feeling.
Wow, powerful comments. Deidre, Fred, any responses?
I would just echo Jackie's sentiment that we need to acknowledge our patients' input, and we need to act on it. They shouldn't come back to our facilities and have the same experiences over and over again. They need to see that we have listened, but we've acted and we've responded to make changes. I think that's easier, again, back to this, the sentiment of culture, when you create a culture where that is just what you do. And I'm very proud to say that SSM is, again, working very hard to create a culture where this is what is expected. And it does need to come from the top, very much so. So everyone knows that we are expected to not only provide exceptional care, but of course, compassionate care and culturally competent care. So it just needs to be ingrained, and health systems have to have a strategy in place that's just ongoing. You can't let up, you can't relent, because we've been, we've been battling this for a while now. And if we let up even for a temporary time, we could easily revert back to some not so appropriate practices. So we have to just keep ourselves accountable and keep pushing ourselves to do better. And we can do better. We're certainly not perfect, and SSM is on that path to doing better. But the last thing I'll say is, I mentioned it again, we just have to have more providers from our communities. We need more providers that look like many of the communities that we're serving. And that's kind of a long-term approach. Again, I know one you work very hard on, Dr. Ross, but I'm of the sentiment that we have to get more providers of color in our hospitals.
Yeah, unquestionably. Thank you.
And the health department, so we have a practice of going back to the basics. Innovation can do a lot, but if the implementation isn't appropriate, it can actually do more harm than good. So by going back to the basic and really creating a culture that embraces all humanity is really what we have to do. So making sure that everyone that comes through our doors feel like they're valued, feel like they are have something to contribute, and feel like we really care is really important. So that really speaks to the message that Jacqueline Randolph was speaking about. Making sure everyone feels appreciated, making sure everyone feels like they have a sense of worth. And we have a responsibility to make sure individuals feel that when they enter into our space, or if we enter into their space. Because we have, again, when we're meeting people where we are, oftentimes it's not in the brick and mortar facilities that we've created, or the ivory towers that have been created where we do our work, but it's really out in community. It could be in someone's home, it could be in a community center, it can be in a place of worship. But we have to make sure that we're always adamant about embracing humanity and implementing culturally and linguistically appropriate services wherever we are.
Great, thanks. Great responses. So are there questions now? I don't know if the questions were posed. I didn't see any questions in the Q&A section. So I'm just looking at the chat here, seeing if I didn't miss any of these questions. So I'm going to ask that the audience, the participants, place questions in the Q&A so we can review those. Let's give you a minute. I don't want to, a few seconds rather. I don't want to push the panelists so much. I want them to really hear from the audience. So I think here's one. States in terms of increasing the number of providers that look like our patients, what specific plans are in place for increasing those numbers, from doctors and nurses, I should say, to all providers? How do we make that happen?
So I'll speak just briefly on some initiatives that we have implemented in our system. And one is, being intentional in your recruitment, and having a team to dedicated to that specific work. For example, when we were recruiting nurses from the Caribbean and to some other locations, we were very intentional, not to exclude anyone, but we were very intentional on, we need nurses that look like our patients, that have different cultural backgrounds and understandings. So we are just being intentional on targeting specific providers, nurses, team members, to ensure that we have a diverse staff to treat diverse populations.
Appreciate that. Let me just give you a brief anecdote, Jackie. I just had a patient in the hospital who had a kidney condition. I brought her in for a kidney procedure, but because of the COVID status, the hospital was so busy, her admission was delayed for almost 3 or 4 weeks. When I finally got in, she was quite angry, and she was African-American, young African-American female, late 20s. She was quite angry. She's stating that this system doesn't care about us, meaning young Black females, or young Black people. And so I literally had to sit down next to her and hold her hand for several minutes and say, I'm here for you. I'm here for you. Because she wanted to leave the hospital feeling that, why should she trust us if they had denied her access to care? It didn't matter that it was a systemic issue. It didn't matter that the hospital was at capacity. That was not part of her reality. And so someone had to explain that. And all three of you have identified ways of really connecting in that bidirectional manner with patients to really explain what's happening. But I'm not naive to say that my ethnic concordance with this patient didn't carry the day there. I think that she looked up and she saw a Black doctor. And she, anger didn't dissipate, but she at least felt that she was going to give us another opportunity to take care of her. So I just want to throw that out because this really illustrates all that we've said over this time period, how do we truly build trust and not dismiss the concerns of our patients. I want to end on this whole concept of trauma-informed care. Because that, in essence, is what we've all been talking about. How do we approach patients and talk about what's going on in your lives as opposed to what's wrong with you? Can you all speak about effective ways that you personally have approached patients in a trauma-informed manner? And what ways should we what should we be doing? What should be doing at your institutions to really incorporate trauma-informed practices? And anyone can start.
Yes, I'll start. So in the health department, so we do, although a lot of our medical services are contracted out, we do provide other public health services to the community at large. And so we make sure that all staff are, one, properly trained, but also make sure they're aware of some of the baggage or some of the hurt and trauma that people may be bringing with them, and teaching them how to listen. So a lot of times people just want someone that actually wants to, that actually is going to take time to listen to them versus just taking a blood sample for HIV test or STI testing or other testing that we may offer. They want someone that's going to listen to them and hear what may be happening in their life. And that really can help change the dynamic between doing a healthcare visit. The other thing that we have to do, not only training out, make sure our staff are properly trained, we also have to make sure we're implementing policies that support that practice. Because if we don't implement policies, then the practice may not be sustainable and really be dependent on certain individuals being in place. And so when we rely on individuals, that really prohibits or limits the ability to have sustainable processes over time. And so when a certain individual may leave, then you go back to the status quo before, and that really builds distrust between community members and different agencies. And so really making sure we have sound policies that are implemented to support this very critical work is imperative.
Thank you, Fred.
And I'll just add to that really quickly, Dr. Ross, because I totally agree and support Dr. Echols' comments. And I just want to add that having the proper resources. So social workers, case managers, and professionals who this is their work. They know it, they understand it, and they can engage with patients in a way that maybe that bedside nurse cannot. And, you know, I know that there are times where there are some baggage that a patient will walk in the door with that's above my skill set, right? So, you know, knowing when to reach out for additional resources and having them available in the moment, not handing a patient a card and say, hey, call this number for social work. Like, it's really important that resources are available to help address those issues in the moment, because that may be your only shot. That may be your only opportunity to get that patient what they need and even to come back to the facility. So having the proper resources, I think, is very important, and executing on, you know, the things that you learn while you're listening, and making sure that the patient is acceptable. You know, because that can be a barrier as well. You could have all these resources and, you know, have your process in place, and the patient may not be ready. And you might not be that person that they want to talk to that about, right? So there's really a combination of intentional acts and actions, I think, that's going to help us make the progress.
Again, I'm very community focused. I don't work in the ministries on a daily basis, but I want to also lift up our case management and social work department, because I work very, very closely with them on a lot of our community health initiatives. And they really are the experts. They really are the connectors, the ones really trying to get our patients most in need the help and services that they seek. Additionally, the community partnerships that I referenced earlier are very much connected to our case management and social work departments. So we know our hospital staff are very maxed out, limited capacity. So what these partnerships have allowed them to do is be really an extension of our case management, and be that extension being the additional expertise in addressing social needs, such as housing, such as food access, such as care coordination. That has been the beauty of those partnerships. So again, I also do want to lift up our case management in terms of your question, Dr. Ross.
Thank you. Well, let's lift up the case managers and patient navigators. They do yeoman's work. This has been phenomenal. I learned so much from the three of you. And I want to now turn this over to one of SMA co-chairs, Iffy, who will close this out. So Iffy, it's all yours.
All right, thank you, Dr. Ross. On behalf of WashU SNMA, I'd like to thank our panelists, Dr. Fredrick Echols, Jacqueline Randolph, and Deidre Griffith again. And again, I'd like to thank our moderator, Dr. Will Ross. Additionally, we'd like to send a huge thanks to the Office of Diversity, Equity, and Inclusion and the Office of Diversity Programs, and all those in those offices who were instrumental to coordinating this event, especially Andrea Bibbs, Dean Lisa Stevenson, Audrey Coleman, and Aaron Stamp. Finally, we'd like to thank the audience for your engagement and participation with this event and for tuning in. And again, if you'd like to see a recording of this event, it'll be available online on the Office of Diversity, Equity, and Inclusion website. And the link for that will be in the chat. All right. Thank you all very much and have a very good evening.